Hi, everyone, and good evening. Welcome to Young Survival Coalition's educational presentation, Genomic Testing in Young Women, Can I Skip Chemo?, featuring our speaker, Dr. Polly Niravath. We would like to thank Genomic Health, who is generously supporting tonight's program. My name is Michelle Esser. I am the Senior Program Manager for Research and Advocacy at YSC, and I will be your host this evening. A few housekeeping items, and then Dr. Niravath will share her presentation with us, followed by a question and answer session. If you have any questions that you would like answered during the Q&A session, please post your questions on the YouTube live chat or on the Facebook event page. You can also note any technical difficulties that you may be having in those same spaces. In addition to Genomic Health's support of our program tonight, we also have a lot of behind-the-scenes help. I'd like to give a shout out to Andrea Hutton in California and Joanne Hayashi in Hawaii, both YSC STAR volunteers, for their help in letting us know that the program is running smoothly. I also want to thank Mary Atwater-Kelman, YSC's Associate Marketing and Communications Manager, who is monitoring our technology on the back end of things and has done a lot of time and effort figuring out the best format for our program tonight, as well as Maida Sutliff, our YSC Regional Field Manager, who's helped us test the technology. So many thanks to everyone. It really takes a village. If you find tonight's program interesting and will be attending the YSC Summit in Oakland, California in March, then I encourage you to check out the Genetics versus Genomics breakout session, which will be led by Dr. Stephen Schack, the co-founder and Chief Scientific Officer of Genomic Health. Finally, our program tonight is being recorded and will be available for viewing at any time on YSC's YouTube channel, YSC. I'm really excited that Dr. Niravath is joining us tonight for this program. I met her at the 2015 San Antonio Breast Cancer Symposium, where she very graciously allowed YSC to film her speaking about the optimal endocrine therapy for young women with breast cancer. You can still see this video on YSC's YouTube channel, along with our other 2015 San Antonio videos. A native of the San Fernando Valley in California, Dr. Polly Niravath completed her undergraduate education at the University of Southern California with majors in biology and religion. She then earned her medical degree from the University of California in Irvine. She went on to complete her medical residency and oncology fellowship training at Baylor College of Medicine. Dr. Niravath currently works at the Houston Methodist Cancer Center. She has a special research interest in breast cancer survivorship, with a major goal to improve on offering comprehensive care to patients from diagnosis to treatment to long-term survivorship care. Most of her research focuses on minimizing treatment-related side effects for breast cancer patients. She is fluent in Spanish, enjoys traveling, jogging, and reading, and she always welcomes a good challenge, including marathons and triathlons. And without further ado, I will turn it over to and welcome Dr. Niravath.
Hello, thank you, Michelle, for that kind introduction. As Michelle said, my name is Dr. Polly Niravath. I am a medical oncologist at Houston Methodist Hospital, and I'm excited to be talking to you guys today in my very first live webinar, so you'll have to excuse any technical difficulties that we have along the way, about genomic testing and whether or not it can help some women make the decision to skip chemotherapy. So with no further ado, we'll go ahead and start the presentation, and afterwards we will have some time for some questions. So if you have any questions, please write them down, and I'm very happy to answer them at the end. Okay, so my disclosures, I have served on a one-time advisory board for Genomic Health, and I also serve as a consultant for Novartis. The objectives for this talk: we would like to, hopefully by the end of this talk, help you understand what genomic testing is and help you to be well equipped to discuss genomic testing with your doctor, if applicable, and to comprehend the differences between two of the most common genomic tests that we use. And then finally, at the end, I'm going to discuss a little bit about the risks and benefits of more aggressive endocrine therapy that's available for young women. So first, I'm going to start with a simple case history of a fictional woman named Anne, who is a 39-year-old Caucasian woman. She had a left lumpectomy, which revealed 1.6 centimeter grade 3 breast cancer with 1 out of 3 axillary sentinel lymph nodes positive for micrometastases, meaning a very small amount of cancer. The definition of a micrometastasis is 0.2 millimeters or less. So she was estrogen receptor positive, very strongly so, progesterone receptor positive, negative. And so she asks this question, can I just skip this whole chemo thing and go straight to radiation? And there are a lot of things in her favor for doing this. She has a small cancer, only 1.6 centimeters, and only 1 lymph node had a very small amount of cancer in it. So the question is chemotherapy going to benefit her? And one of the things that we can use to answer that question is genomic testing. What is genomic testing? It's a test that we can do on the tumor itself that analyzes the gene expression in the cancer. The reason that we do it is because it helps us find out which cancers will truly respond to chemotherapy and which ones really will not, and thereby allowing us to spare some women from the toxicity of chemotherapy. And people ask me all the time, is this the same thing as genetic testing? And actually, genomic and genetic testing are 2 different things. When we say genetic testing, looking at your entire genome, meaning that all the genes that you got, half of which you got from your mom and half of which you got from your dad. So this is usually done by looking at your own bodily fluids. So meaning like looking at your blood or your saliva, we can look at your genes to see if you carry any mutations which could increase cancer risk in the future. So also just to get some things out of the way in terms of medical jargon, whenever we talk about these genomic tests, we tend to discuss a prognostic test and a predictive test. All that means is that a prognostic test is one that basically can tell us whether or not the cancer is a high-risk cancer that's likely to come back. Whereas a predictive test can tell us whether a particular therapy may actually prevent a cancer recurrence. Ideally, we would want any test to be both prognostic and predictive, meaning that it will tell us if a person has a high-risk cancer that we should be concerned about. And then furthermore, it will predictively tell us whether or not certain therapies could help reduce that high risk of recurrence. So before we had all these fancy genomic tests that were prognostic and predictive, obviously we were using other things. And really we were kind of using these old-fashioned clinical features. So things that we still talk about and that we still use. And these are wonderful adjuncts to help us in deciding whether or not somebody would benefit from chemotherapy. So these are things like the grade of the tumor, the size of the tumor, whether or not lymph nodes are involved, if the person is estrogen or progesterone receptor positive. So for example, people who have triple negative breast cancer will very commonly require chemotherapy, whereas women who are estrogen or progesterone positive may possibly avoid chemotherapy in some cases. HER2 status also helps us decide. So for example, HER2 positive women will almost always get chemotherapy, except for perhaps the very smallest and most lowest risk HER2 positive cancers. We also take into account the age of the patient and the overall health or performance status, meaning how active is this person, how likely are they to tolerate chemotherapy. So in order to help us understand a little bit about these genomic tests, which are, there are a few different genomic tests on the market. And I'm going to discuss 2 of the main genomic tests that we use in clinical practice. And this was the main clinical trial that was just recently released to help validate one of the genomic tests that we use, and it's called Manaprint. And this trial design was a little bit complicated, so I don't want to get too bogged down in it. That they took many women. This is all the women here all together. It was almost 7,000 women. Some of them were very low risk. So they just got plain old endocrine therapy, meaning tamoxifen or aromatase inhibitors. Other women were clearly high risk. So those women were treated with chemotherapy followed by endocrine therapy. And those 2 are kind of in clear categories. Focus of the study was actually this group in the middle here, which was about 32% of the total group. These were the discordant cases. It means that I talked about earlier, things like tumor grade, tumor size, lymph node status, might have been high risk, But the genomic test that we used, which is called Manaprint, came back low risk. So our clinical intuition is telling us one thing, and the genomic test is telling us another. Now, the trial was actually designed specifically to look at this one group, which is now only 1,550 of the initial nearly 7,000 women that started on the trial. So this group, this small group, is a group that is felt to be clinically high risk, meaning they have high-grade tumors, large tumors, lymph node involvement, but yet they are considered to be low risk by Manaprint, by the genomic test that we use. So the question is, what do we do with this group? And all of the data that I'm going to show you is based on this. Now, when we look at the overall study population for this trial called MINDACT, this was a total of almost 7,000 women. In general, pretty low risk type of group. Only about 1 in 5 of the women had any positive lymph nodes. Many of them were estrogen receptor positive, and most of them were stage 1, meaning tumors that were less than 2 centimeters. However, when we look at that subgroup that I just told you about, the people who were considered to be clinically high risk but low risk by the genomic test, then we look at a much smaller group, only about 1,550 women, and now suddenly nearly half of them are lymph node positive. So this is why they ended up in the clinical high risk group, because many of them were lymph node positive. Most of them were estrogen and progesterone receptor positive. A group of people that also has bigger tumors. 58% of them had tumors greater than 2%. So in general, a much higher risk group than the overall study population. And this is to show us that, like most clinical trials, we were lacking in MINDACT the very, very young women who are less than 35, as well as the older women who are greater than 70 years old. So we have a good chunk of what we would call younger women, 35 to 50. But most of them are actually in this age group of 50 to 70 years old. Now, what this trial actually showed, and that we talked about, who have a high clinical risk and a low genomic risk. So these are people who normally would have gotten chemotherapy if we didn't have the genomic test to rely on. We actually found that for those people, whether or not they got chemotherapy, everyone did just about the same. You can see that this line here is telling us how many women are surviving without any metastatic disease. And we can see that the two lines are almost the same. So this is a group that normally would get chemo, but we're finding out that even if we don't give chemo to this group, they seem to do just as well as if they had gotten chemo. And this here is just kind of a close-up view, blown up, of this same curve. You can see that in the end, these women actually really turn out to be the same. And specifically, to look at the numbers, the women who got chemotherapy ended up having a 95.9% 5-year survival with no distant metastases, meaning that almost 96% of them were able to stay cancer-free. Whereas those who did not get chemo, 94.4% of them remained cancer-free. And this difference was not statistically significant. However, it should be pointed out that there was a 1.5% difference in favor of chemo, and it did not meet statistical significance. And we'll talk about that a little bit later. Additionally, out of this group, this high clinical risk, low genomic risk group, about 34% of them were less than 50 years old, so a substantial percentage were young women. In terms of looking at lymph node positive versus lymph node negative women within this group that we're talking about, you can see that in both cases, women who got chemotherapy versus no chemotherapy is very similar, and they're not different from each other from a statistical standpoint. So we can see that lymph node negative women really didn't get benefit from chemotherapy, it seems, and the lymph node positive women did not seem to have any different outcome based on chemotherapy. And this is important because this is one of the trials that has a larger subset of lymph node positive patients looking at genomic testing. So there was a total of 744 patients in this group that we're talking about who are lymph node positive. So Manaprint is telling us that in some cases, and I'll go back here for a minute, in some cases, we may not need to give chemotherapy to people who we would consider typically to be high clinical risk, because we see that in general, their survival curves are very similar whether or not they get chemotherapy. But it is important to point out that the trial was not designed to ask the question of whether or not chemotherapy gives benefit in this group. The trial was actually designed to find out would be acceptable to omit chemotherapy for this group, meaning that would they have a distant metastasis-free survival that would be greater than 92%. That was how the trial was designed. So really all it's telling us is that it's not a horrible thing to omit chemotherapy for this group, meaning that their survival ends up being quite reasonable, but we truly don't know definitively to omit chemotherapy for these women. And that trial is probably going to be coming up in the future to definitively answer the question, but this is very encouraging data for us to examine this test further. So the main drawbacks of Manaprint are that we only have 5-year follow-up at this point. And as I mentioned earlier, there was a 1.5% difference between the two groups, those who received chemo and those who did not. Because we're talking about a relatively small group of women now, it was only 1,550 women within this larger group that was, almost 7,000 women. Perhaps if we had looked at more women, we would have had a statistically significant difference between the two groups, because 1.5% in some trials actually can become significant if we have large enough numbers. So that could be a signal for a difference. And also, as I just mentioned, the way this trial was designed, not to whether there was a statistical difference in survival between the chemo versus no chemo groups. It was really just asking, if we don't give chemo, will those people do reasonably well? But it wasn't a direct comparison between the chemo versus no chemo groups. So the main bottom line for this particular genomic test, which is called Manaprint, is that for those patients who have high clinical risk, some of those patients could be spared from chemotherapy if they have low genomic risk. So this means that for a woman who would kind of normally give chemotherapy to based on her clinical factors, we could use this test, and if it comes back with low genomic risk, we would have some data to say that perhaps sparing her from chemotherapy would not be unreasonable. However, for those patients who have low clinical risk, even if they have a high genomic score, we find that there is really no difference between those patients who received chemotherapy and did not. So really the utility of this test tends to be more for people who have high clinical risk and the ones that we would be considering chemotherapy for. So the patients who, at the end of the day, would possibly be good candidates for Manaprint would be those who have high clinical risk features, for example, positive lymph nodes or high-grade tumors, where we are considering chemotherapy. And if that patient has a very high desire to avoid chemotherapy, because the main utility of this test is to potentially avoid chemotherapy for patients who would have otherwise received it. And then also, I think the patient, this is important to say, should be willing to accept some uncertainty in the potential harm of omitting chemotherapy, because the single trial that we have that looks at the outcomes with Manaprint really was not robustly designed to answer the question of whether or not it's truly okay to omit chemotherapy. What it's saying is that it seems that if we don't do chemotherapy, people don't seem to do horribly badly. It's really all that we have. And until we have more trials that are designed to answer the question, it's difficult to say with any certainty that we know that chemotherapy can be safely avoided. And also for those patients who have a poor performance status and are not very active and not likely to tolerate chemotherapy very well, and we're kind of looking for a reason to not give chemotherapy, this Manaprint could be very good supporting evidence to potentially avoid chemotherapy. So in this case, hypothetically, if her Manaprint, for example, comes back as low risk, and she's very interested in not doing chemotherapy, we could discuss the data and say that in the trial that we have for women who are very similar to her, the people who had low risk Manaprint scores seem to do fine without chemotherapy. And this would be an option for her if she wanted to avoid chemotherapy, and it would be very reasonable. Now moving on to the second case history to discuss a different genomic test that we have available. In this case, this woman is a 37-year-old Latina woman. She had a right lumpectomy with a larger breast cancer. Her cancer was 4 centimeters, but it was low grade, grade 1, with 0 out of 2 axillary sentinel lymph nodes with cancer. So we would call this a stage 2A breast cancer involved. And she's also strongly estrogen positive and progesterone positive and HER2 negative. So the question with her is to give chemo or not to give chemotherapy. The main things that would push us towards chemotherapy in her case would be her young age, which very often tips us toward chemotherapy because we know that in general, younger women tend to get more benefit from chemotherapy. And then also her tumor size. 4 centimeters is a fair size for breast cancer. And these are the main things that would push us towards chemotherapy in that woman. So this is a particular patient where the Oncotype DX test could be very helpful. Oncotype DX is another genomic test that looks at a different set of genes. Manaprint looks at about a set of 70 genes. This test looks at these 21 genes that are listed here. So it's really just kind of a different recipe. And with Oncotype DX, we get back a recurrence score. And you can see here that this particular recurrence score was 10, which puts it in a low risk category. So what does that mean? That number correlates to a prognostic meaning how likely is this cancer to come back. For somebody with a score of 10, you can see that their risk is approximately 6% of having a recurrence of breast cancer at 10 years. So in general, a fairly low risk cancer. And I think more importantly, Oncotype also tells us about the predictive benefit, meaning is this likely to prevent, is chemotherapy likely to prevent cancer for this patient? And you can see that for people who have a low risk recurrence score, which is measured here with these green lines, you can see that people who got tamoxifen alone versus tamoxifen plus chemotherapy had almost no difference in their outcomes. Those lines are really right on top of each other as we follow it along. However, the people who had a high recurrence score, which are here in red, tend to have actually about a 28% absolute benefit from tamoxifen plus chemotherapy. So you can see here the solid red line is people who got tamoxifen with chemo, and this dotted red line is people who got only tamoxifen. And you can see that these women have a very, very high risk of recurrence. The lower this line goes, this means the more that people are recurring. So clearly these people are getting a big benefit from chemotherapy. Their risk of recurrence goes from here down to there. And recently there was a paper that was released that was looking at a specific group of people that have an Oncotype score of less than 11, less than or equal to 11. And we see that their 5-year disease recurrence rate is about 99%, 99.3%, meaning that almost all of these women do not have recurrence of their breast cancer going out to 5 years if they have a very low Oncotype score of 11 or less, which is really quite impressive. There are, of course, some drawbacks to using this genomic test, though. One issue is that we don't have as much data as we would like for lymph node positive patients. So for women that are estrogen positive and have lymph nodes involved, Oncotype DX may not be the ideal test to use. There are some studies that look at lymph node positive results for Oncotype DX, but those results are not quite as robust and not quite as reliable. Also, Oncotype DX can only be used for estrogen receptor positive breast cancer, whereas Manaprint can be used in other types of breast cancer as well. And Oncotype DX does have this intermediate category result. So the results can come back as high risk or low risk, in which case we know what to do. If somebody comes back as low risk, we don't give any chemotherapy. And if they come back as high risk, we do give chemo. However, when they come back in this intermediate risk category in the middle, that's much more of a gray area. We really don't know whether or not those people would benefit from chemotherapy. And then finally, the main drawback of Oncotype DX is that the cancer genes that are analyzed reflect those same pathologic criteria that we as oncologists use to make clinical decisions, meaning it looks at estrogen receptor, progesterone receptor, markers of tumor grade and proliferation. So many times oncologists are questioning how much the Oncotype DX tests adds to their own clinical judgment. But there are many cases where we can look at the tumor and we'll be a little bit surprised by the way Oncotype DX comes back. So now who should use Oncotype DX then? So I would recommend that women with estrogen receptor positive breast cancer and lymph node negative breast cancer are the ones who should probably be using Oncotype DX. Also, if the pathologic criteria is a little bit discrepant, meaning that the person has a high grade but a low cancer proliferation, those two are not in agreement with each other. And this is not that common. Usually if somebody has a high tumor grade, they'll have a very high proliferation number. But every now and then these two numbers can be off, in which case the Oncotype DX can serve as a very good tiebreaker to decide whether or not the person would benefit from chemotherapy. And then finally, we can use Oncotype DX to prove that a larger tumor with favorable biology that may not require chemotherapy, similar to the case that I mentioned earlier, Claudia. So this woman has a tumor that's a little bit larger, and she's a young woman. So these are some things that would make us think that maybe she needs chemotherapy, but the biology of her tumor, given that it's low grade and lymph node negative and strongly estrogen and progesterone receptor positive and low proliferation, all of those things are pointing towards a tumor that probably would not benefit from chemotherapy. So she's an excellent candidate for Oncotype DX. And in her case, hypothetically, if we ran it, it may come back with a very low score of 2, for example, which tells us that not only is her risk of recurrence from the cancer very low, but her benefit from the chemotherapy is also going to be so low that there would be no purpose in giving her chemotherapy. So kind of to summarize, between Oncotype DX and Manaprint, which are the two main genomic tests that we tend to use in clinical practice. Oncotype DX has this intermediate risk category, which is a little bit of a gray area where the data is not so clear whether or not those women should receive chemotherapy, whereas Manaprint does not. Manaprint has only low and high risk. Of cancer, Oncotype DX is very clear. You can only use it for estrogen receptor positive breast cancer, whereas Manaprint can technically be used in any type of cancer. Almost all of the strong data that we have for Manaprint, especially for its use in the predictive setting, meaning deciding whether or not to give chemotherapy, is really in estrogen receptor positive patients for the most part. So I would be very hesitant to use it for anyone outside of estrogen receptor positive patients. And as I mentioned earlier, triple negative patients and HER2 positive breast cancer patients tend to receive chemotherapy anyway. So Manaprint may not be as helpful among those patients. And then in lymph node positive breast cancer, I would say that Oncotype DX is probably a little bit less validated, and there are some guidelines that suggest not using Oncotype DX for lymph node positive patients because the data there is just not as well developed. Although we do have a trial that's ongoing now, which some of you may have heard of, called the Responder trial. And that trial will hopefully help us understand whether or not we can use Oncotype DX in lymph node positive patients. We eagerly await the results of that trial. And Manaprint has a little bit more data in lymph node positive patients, data exactly definitive either. And again, we're waiting for more trials to help us answer that question a little bit better. Oncotype DX looks at 21 genes, whereas Manaprint looks at 70 genes. And then the Manaprint looks at genes that are entirely independent of estrogen receptor, progesterone receptor, and HER2. So there is a little bit more mystery there in Manaprint in terms of what those genes are actually assessing. Oncotype DX is not technically FDA approved, although it is the industry standard that many of us use to help make decisions for chemotherapy. And Manaprint did get FDA approval back in February of 2007, but I should say that that FDA approval was only for prognostic use, meaning telling us whether or not a cancer is low or high risk. It has not been FDA approved for predictive use, meaning can we skip chemo? We don't have that data yet because it's still being evaluated. And the cost is about the same for both tests, roughly $4,000. So just to quickly talk about metastatic patients, where do they fit in all of this? Manaprint and Oncotype DX do not apply to metastatic patients or patients who are receiving neoadjuvant chemotherapy. It has not been studied in those settings. We do have genomic testing that we can do for metastatic patients through companies like Foundation One and others, where they look at multiple cancer-related genes to see which ones have mutations in them. But these results are very difficult to interpret, and they're not yet clinical prime-time use, I could say. So meaning this is something that's being studied. And there is a large trial going on all across the world, actually, international trial called the NCI MATCH trial, which is looking at metastatic patients, finding specific tumor mutations within those cancers, and trying to target those with special targeted medicines that are not chemotherapy. And once we get those results back, that may be a way that we can use some genomic testing in metastatic patients. Okay, so that concludes the part about genomic testing. Okay, so let's say that you've gone through this whole process with your doctor, you need chemotherapy, and at some point you may get to the point of needing endocrine therapy, and then what? That's kind of the next step. One of the main questions for endocrine therapy is how aggressive we should be, especially when it comes to younger premenopausal women. We've had a lot of data that's come out recently that looks to be very impressive. So for example, the ATOM trial was looking at 10 years versus 5 years of tamoxifen. And we found that there was a reduced risk of breast cancer recurrence as well as breast cancer death when we did 10 years as opposed to 5 years of tamoxifen. And Atlas showed us very similar results with 10 years versus 5 years. And then more recently, we had the two trials called SOFT and TEXT, which came out. And those trials told us that suppressing the ovaries, by either surgically removing them or giving women medicines to basically put them in premature menopause. So ovarian suppression plus medicines called aromatase inhibitors are actually better than tamoxifen. And all of these numbers look very impressive when you see them, 25% reduced recurrence risk, 34% reduced recurrence risk, less breast cancer deaths. But when we actually dissect these trials out, the benefits are actually very, very small. So the numbers that you're seeing in black, these are relative risk reductions, whereas the numbers in red is the true absolute risk reduction. So meaning that in absolute terms, 2.6% less women had a breast cancer recurrence in the ATOM trial when they got 10 years versus 5 years of tamoxifen. So that means that out of 100 women, only about 2 to 3 women would actually benefit from the extra additional tamoxifen. And you can see that across the board, all of these trials are actually showing a very low absolute benefit, meaning that you really have to hunt for that rare woman, maybe 4 out of 100 or 2 out of 100, that will truly benefit from the more aggressive chemotherapy. So this begs the question, two main questions actually, is that how can we find those few women, those 2 to 4 out of 100 women who are truly at high risk of recurrence? And within that group, can we predict who's going to really benefit for the more aggressive endocrine therapy? Because we know that not everyone needs aggressive endocrine therapy. So how is it that we find those people who really need it and make sure we get it to them? Because, as you know, there's no such thing as a free lunch. Each of these more aggressive endocrine therapies comes with a lot of side effects. This is a chart from the SOFT and TEXT data. So this was the trial that used ovarian suppression in young women. And you can see that when we suppress the ovaries and create premature menopause, you're seeing phenomenal rates of hot flashes. More than 90% of women are having hot flashes. And overall side effects, grade 3 and 4, up to 30% of women are having grade 3 and 4 hot flashes, which means that, grade 3 and 4 adverse events overall, meaning that these are side effects that are significantly affecting quality of life. About half of women experience depression. Insomnia is very common. We see a high rate of hypertension as well. A lot of these musculoskeletal symptoms, this usually means aches and pains, that we see a lot. And this is higher with women who are getting aromatase inhibitors. So these are medicines like Arimidex, Femara, and Aromasin. Also, we see a much higher rate of osteoporosis. Vaginal dryness is very high. Dyspareunia is just a fancy word of saying pain with sexual intercourse. This is also very high, up to 30% in the women who are getting ovarian suppression plus aromatase inhibitors. So a lot of side effects here in terms of quality of life for a very small absolute benefit in terms of breast cancer recurrence. And so not surprisingly, with all these side effects, we can see that women don't really stay compliant with these medicines very often. So here, this blue line are the women who actually continued tamoxifen for a total of 10 years in the Atlas trial. And you can see that these women are kind of dropping off like flies. By the time we get out to 10 years, only about 60% of women have remained compliant with the tamoxifen because there are so many side effects that we're asking these women to endure for a total of 10 years. So we obviously have to select these women very carefully. We still really don't quite understand who's going to have an early versus a late recurrence. And there are some different tests that are going on now for this that are being studied in clinical trials to help us understand who's going to have a late recurrence and therefore will benefit more from a longer period of endocrine therapy. Because those women may be the ones that actually need 10 years or maybe even more of estrogen lowering therapy to prevent a late breast cancer recurrence. And also, who will benefit from ovarian suppression plus aromatase inhibitor over just plain old tamoxifen by itself, which used to be the standard of care. So who are these women who are going to really benefit from these more aggressive types of endocrine therapy that come with more side effects? We obviously want to target these aggressive therapies towards the women who truly need them. So what we can say is that we need to be taking into account the a priori, or meaning the initial risk of the patient. So these more aggressive therapies should not be directed towards everyone who has estrogen positive breast cancer, but rather towards those women who have very high risk of recurrence, either by clinical features, which we talked about earlier, or perhaps by these genomic tests. So these genomic tests are now being looked at to see whether they can predict more aggressive endocrine therapies. But right now, we only have the clinical tools at our disposal. So meaning looking at the pathologic criteria of tumor grade, tumor size, and lymph node status to help us decide which people are at truly high risk. Another important issue is which treatment will the patient remain adherent to? So for example, I have one patient who's a yoga instructor, and for her, it's very important to feel, to be able to move her body well and to be able to exercise. And she was somebody who really balked at the idea of having joint pains from aromatase inhibitors. So she's somebody who I started on tamoxifen instead of aromatase inhibitors because I knew that for her quality of life, she would not be able to have those stiff joints that aromatase inhibitors so commonly cause. And it's more important that she gets an effective medicine that she takes than trying to prescribe a medicine that may be slightly more effective, but one that she's never going to take and is going to sit in her medicine cabinet. So consider is that for women who've just completed chemotherapy, because the chemotherapy has already suppressed their ovaries, we know that ovarian suppression has less side effects for those women. So for a woman who had no chemo and is coming out from surgery and just going to go straight to estrogen lowering medicines, ovarian suppression will likely be very, very toxic. But for somebody who just completed chemotherapy, she may not notice as many side effects because she's unfortunately already gone through many of those side effects with chemotherapy. In general, for premenopausal women, the clinical recommendations based on the trial data that we have is to consider ovarian suppression plus aromatase inhibitor therapy for women who are less than 35 years old and who had an aggressive breast cancer that actually did require chemotherapy, and for those women that had positive lymph nodes. This is the group of women that tends to benefit most from ovarian suppression plus aromatase inhibitor. And in terms of the question of prolonged tamoxifen therapy, this could be a good idea for women who have high-risk biology and for those who remain premenopausal after 5 years of tamoxifen. Because after 5 years of tamoxifen, for those premenopausal women, when we stop the tamoxifen, they will still be producing a lot of estrogen in their body because their ovaries are still working, they're still ovulating and producing estrogen, and that estrogen could theoretically go and feed the tumor. So that additional 5 years of tamoxifen would protect them from that estrogen in that case. So eventually, if we're coming down the road, as I kind of mentioned earlier, some of these genomic tests are actually being applied to large clinical trials that have already been done to try to go back retrospectively and identify the women who will benefit from more aggressive endocrine therapy. And if we find tests that are effective at singling out those women who are going to benefit, then we can create clinical trials to actually validate those tests and see whether we can use them to tell us who should be getting ovarian suppression and who should not. And that is the end of our talk. I'm happy to take any questions that you all have.
Thank you so much, Dr. Niravath. That was great. It was a nice in-depth presentation and yet very clear and easy to understand. So thank you so much. We did have a couple of questions come in. One was about whether genomic testing is covered by insurance.
Okay, yes. So genomic testing is covered by insurance for most indications. The ones that are the most proven, as I said, are Oncotype DX and Manaprint. In almost all cases, for women who meet the criteria, genomic testing will be covered, and it is something you should talk to your doctor about if you think that you might qualify for.
And if you qualify for both Oncotype and Manaprint, would it make sense to get both tests run?
You know, I would say no. So that can be very complicated because what can happen is because Oncotype and Manaprint are looking at two totally different sets of genes, you could come up with discordant results. So meaning the Oncotype, for example, could come back as low risk, the Manaprint can come back as high risk, and then what would you do with the results? So usually what we try to do is we try to tailor the test. So meaning that, you know, we have more data, for example, to use Manaprint in lymph node positive patients. So I tend to use that more in my ER positive, lymph node positive patients who appear to be high risk, but maybe if their Manaprint comes back low risk, we can avoid chemotherapy. And then we use Oncotype DX more in the estrogen positive, lymph node negative population. So it's a slightly different set of women that we use it in based on the trials that we have. So we try to match the patient to the type of patients that were actually included in the trials that validated those tests.
And will we know in the future what to do about those Oncotype DX scores that are intermediate? Are there any ongoing or planned studies to examine that?
Yes, absolutely, absolutely. So right now there is a trial called the Responder trial, which I mentioned briefly. The Responder trial is actually looking at women who have Oncotype scores of 25 or less. 30 is that intermediate range. So that's going to help us tease out a little bit more of that intermediate range and understand whether or not those women will benefit from chemotherapy. And then we also have the Taylor RX trial, which is also trying to hone in on that intermediate group and help us understand whether or not those women need chemotherapy. So hopefully within about a couple of years, we may have those results.
And I know generally young women sometimes tend to be treated a little more aggressively, and chemotherapy is almost automatic, or it used to be. How willing are oncologists to accept the test results of Oncotype or Manaprint if it does come back and shows that the chemo may not actually benefit the young woman?
That's a great question. And I think it varies widely across the board. So there are some oncologists out there who I think just by the virtue of the fact that the woman is fairly young and she has breast cancer, they'll give chemotherapy to almost anybody who comes into their office with such factors. I personally, and I think most of my oncology colleagues would not really agree with that. We now understand that the biology of the cancer is extremely important and can definitely change management. So there is a little bit of a lower threshold to give younger women chemotherapy because we know that the benefit is greater for younger women than older women. But that's exactly where these genomic tests can be the most helpful, because looking at the actual biology of the tumor is a much more objective way to say whether or not this individual sitting in front of you has a cancer that's likely to respond to chemotherapy, instead of using overall generic type of features like the patient's age, for example.
And since ER-positive breast cancer can have late recurrences, say 10 years, 15 years, or more, I'm trying to reconcile that with the follow-up in the Manaprint and Oncotype DX trials, and wondering if that is long enough to see whether distant recurrences may still occur if you do chemo or not do chemo, or do they just predict the more immediate recurrences? Not sure if the question makes sense. I'm trying to put it in there.
Yeah, I think I understand what they're asking. So the answer is that this question of early versus late recurrences is something that is difficult to study, first of all, because it requires such long-term follow-up. When we're talking about estrogen receptor positive breast cancer, more than half of the recurrences, unfortunately, occur after 5 years. So this means you have to have a prospective clinical trial where you're following women out for 15 or 20 years. It obviously takes a very long time to collect that data. So what we do have is we have some data that looks back at women who had Oncotype DX. And we do think that there are some women with Aquatech DX who can be helped to understand if they're going to have a late recurrence. But that's really kind of very early data and not as reliable. There's another test, which is another type of genomic test called breast cancer index. It's probably made the most headway in trying to differentiate between late recurrences and early recurrences. And it again uses a different set of genes entirely than either Oncotype or Manaprint, just to make things a little bit more confusing, right? But the short answer to the question is that for Oncotype and Manaprint, we really can't differentiate between early versus late recurrence. It just tells us about recurrence risk in general and response to chemotherapy overall, but not the timing of the recurrence.
And then for triple negative breast cancer, typically I think the only treatment is chemotherapy. Just curious, how often does Manaprint performed on a triple negative tumor show that chemo may not be required? But is that an unusual result?
It would be unusual. So most triple negatives would come back as a high risk. But I'll be honest with you, we don't have a lot of that data because most of us, when we see triple negative breast cancers, will be offering chemotherapy. And I think that that is warranted at this point because unfortunately with triple negative breast cancer, at this point, there is no other target in chemotherapy. We don't have any validated medicines that we know will reduce the risk of recurrence. And the rate of recurrence for triple negative breast cancer that's untreated with systemic therapy is unacceptably high. So we're not using genomic tests in that arena as much because we don't have an alternative to chemotherapy like we do for endocrine therapy.
And if a long-term survivor has finished their tamoxifen and they finished it before the results that you discussed came out, the soft and the text trials, is there any benefit to them going back to their oncologist and asking if they should restart an endocrine therapy to try and hit the 10 years? Or what are the factors that you look at to make that decision?
Yes, this is a good question. So the trials that were done that look at 5 versus 10 years, they were all continuous. So for example, if somebody's been off of her 5 years of tamoxifen, if she finished it roughly 3 years ago, let's say, there's probably not a whole lot of benefit to going back and putting that woman on an additional 5 years of tamoxifen because that 3-year tamoxifen-free interval replicated in any of the trials. And we don't know if that person would benefit. On the other hand, though, if somebody just recently, let's say within the past 6 months or so, finished their 5 years of tamoxifen, it may be something that you can talk to your doctor about, whether or not they would recommend an additional 5 years of tamoxifen. Usually we would recommend it only for the fairly high-risk women, people who had positive lymph nodes or very aggressive biology types of tumors.
And if someone has a breast cancer recurrence, is genomic testing still a possible option to see if they were hoping to avoid chemo?
Okay, great. So Oncotype DX and Manaprint both have been studied only in the what we call de novo setting, meaning with a brand new breast cancer that's just initially diagnosed. So in the setting of a recurrent breast cancer, we simply don't have that answer. We don't know that whether or not Oncotype DX and Manaprint can be applied. There was another trial in that setting called Color that was released maybe about 3 or 4 years ago. And that trial specifically looked at women who had recurrent breast cancer. And they found that there was absolutely a benefit to chemotherapy for recurrent breast cancer, but we haven't tried using genomic testing in that regard.
And then it looks like a couple questions on the data on young women specifically to support the use of Manaprint and Oncotype DX. I think I saw one of your slides had information on Manaprint, but Oncotype also had young women in their trials. Is that correct?
Yes, so you're asking about, yeah, so Manaprint did have, I believe it was about almost a third of women were less than 50 years old. Yes. So we would consider that a younger age group. But then, of course, the converse of that is about 2/3 of them were greater than 50 years old.
Right. And did Oncotype also have data that included young women in their trials?
Yes. So I don't know off the top of my head the percentage of women who were considered to be younger. But Oncotype does have a wide range of women involved in their trials. Since Oncotype has been around much longer, we actually have much more clinical trial data for Oncotype than we do for Manaprint. And they've enrolled women who are young and old all across the board.
Okay, great. So Mary is telling me that we have, oh, here we go, some more questions. They're saying, I want to make sure I understand the risk of recurrence with just chemotherapy and no tamoxifen with an oncotype of 26.
Risk of recurrence with just chemo and no tamoxifen with oncotype of 26. Yeah, so it's tough. Okay. 26 is that intermediate range, that 18 to 30. Mm-hmm. So the oncotype score, when you get 26, the report will actually correlate for you what the risk is with chemotherapy and then also without chemotherapy. But the short answer to that is that, people who have an intermediate score, usually what we do is we look at other factors. The genomic test is not going to give us a definitive answer of giving chemo or not. So that's when we fall back more on those clinical factors like tumor grade, tumor size, lymph node status, how healthy is the person, how likely are they to tolerate chemotherapy. We just really don't know if there's a benefit in that intermediate group yet.
And if someone is not able to tolerate tamoxifen because of some of the side effects like back pain or something like that, are there other options? What would you suggest if they're saying it's just not tolerable?
Okay, so for somebody who really cannot tolerate tamoxifen, it's difficult. It's a difficult problem. The other options are that medicine that's kind of a sister of tamoxifen. It's called raloxifene, and it tends to have fewer side effects. But the problem with that one is that it has not been validated in premenopausal women. All the studies of raloxifene have been in postmenopausal women. So for a premenopausal woman on tamoxifen who cannot tolerate it, we don't have a lot of great options. I've seen some oncologists recommend raloxifene, but I really don't recommend raloxifene for that group because we just don't know if it's effective for premenopausal women. So that leaves the other options are to do ovarian suppression plus aromatase inhibitor. So meaning either surgically removing the ovaries or taking a medicine to suppress the ovaries and taking an aromatase inhibitor. But typically those will have far greater side effects than tamoxifen.
All right, thank you. I'm doing a final check with Mary to see if, I think we ran out of our questions. But again, I want to thank you so much, Dr. Niravath, for your time tonight. We really appreciated your presentation. It was just excellent. So thank you very, very much. And thank you to everyone that tuned in tonight. Again, this is recorded and you can watch it at any time back on YouTube. So thank you so much.
And thank you so much for sticking around and listening for the audience out there. I really enjoyed giving the talk and I hope that it was somewhat helpful. And if you have any questions at all, please feel free to contact me through that email that I put up on the last slide.
Great. Thank you very much. Have a nice night.
Thank you.